Horas. Saya, Dr. Andriamuri Primaputra Lubis, selaku Ketua Panitia KPPIA Perdatin 2024, pada tahun ini, Perdatin Cabang Sumatera Utara mendapatkan kepercayaan untuk menyelenggarakan pertemuan ilmiah 3 tahunan berskala nasional, yaitu Kursus Penyegar dan Penambah Ilmu Anestesia atau yang disingkat KPPIA. Kami mengundang Anda untuk hadir dan berpartisipasi dalam kegiatan ilmiah ini dengan semangat kekeluargaan dan antusiasme yang tinggi, sembari menikmati segala keindahan, keunikan, dan keanekaragaman kuliner yang ditawarkan oleh daerah Medan, Sumatera Utara.
Saya, Irjen Pol Dr. Asep Pendradiana, selaku Ketua Umum Perdatin mengucapkan selamat atas terselenggaranya kegiatan ini. Semoga acara ini dapat berjalan dengan baik dan lancar. Mari Bersama kita sukseskan dan hadir pada acara tersebut. Wassalamualaikum warahmatullahi wabarakatuh.
Berikut ini adalah cara untuk membuat akun pelataran sehat melalui Satu Sehat SMDK. Pertama-tama, buka link satusehat.kemkes.go.id/sdmk, lalu klik daftar sekarang. Kemudian, isi data yang diperlukan yaitu NIK, nama sesuai KTP, jenis kelamin, tanggal lahir, email aktif, kata sandi, dan konfirmasi kata sandi. Lalu, isi kode CAPTCHA dan klik daftar. Pastikan bahwa data sesuai, lalu centang pada kotak pernyataan bahwa data benar, dan klik konfirmasi. Silakan periksa email aktivasi di email Anda, lalu klik aktivasi akun. Setelah akun Anda berhasil diaktifkan, silakan login dengan menggunakan email dan kata sandi yang sudah Anda daftarkan. Jika sudah berhasil masuk di akun Satu Sehat, silakan klik menu pelataran sehat, lalu klik tautkan akun. Silakan centang kotak persetujuan setelah memahami persyaratan yang ada, lalu klik konfirmasi. Kemudian klik cari pembelajaran, setelah itu Anda harus melengkapi data diri. Jika sudah melengkapi data diri, maka Anda sudah bisa mengikuti pembelajaran yang ada di pelataran sehat.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, saya sampaikan kepada para dokter-dokter sekalian. Terima kasih telah bergabung ke webinar series ketiga dalam rangkaian series webinar KPPIA Perdatin 2024. Pada kesempatan kali ini, kita akan membawakan topik besar dengan judul Airway Management yang akan dibawakan oleh dua pemateri internasional, yaitu ada Prof. Sheila Myatra dan Prof. Jigeeshu Divatia. Baiklah, tanpa membuang banyak waktu, saya langsung serahkan kepada moderator kita. Sebelumnya, akan saya bacakan untuk CV dari moderator kita. Pada hari ini, webinar kita akan dibawakan oleh moderator kita Dr. Andriamuri Primaputra Lubis, Magister Kedokteran Anestesi, Spesialis Anestesi Terapi Intensif, Subspesialis Terapi Intensif Konsultan. Beliau menamati pendidikan subspesialis terapi intensif di tahun 2019, Magister Kedokteran Klinis tahun 2012, Spesialis Anestesiologi dan Terapi Intensif tahun 2011. Riwayat pekerjaan beliau saat ini merupakan dokter spesialis anestesi terapi intensif di beberapa rumah sakit di Medan, seperti Rumah Sakit Columbia Asia Medan, Rumah Sakit Smek, dan Rumah Sakit Haji Adam Malik Medan. Beliau juga menjabat saat ini sebagai Ketua Program Studi Anestesiologi dan Terapi Intensif Fakultas Kedokteran Universitas Sumatera Utara. Baiklah, tanpa membuang banyak waktu, kepada Dr. Andriamuri, saya serahkan.
Suara saya jelas, Dr. Akmal?
Sangat jelas, dokter.
Okay. Thank you for your kind introduction, Dr. Akmal. Hello, everyone. Welcome to the third webinar series of the refreshing course of Anesthesiology and Intensive Therapy. We are excited to have you with us today. The theme of today's webinar is airway management. Today, we have two speakers. The first is Prof. Sheila Nainan Myatra, who will sharing their expertise on tracheal intubation in critical ill adult with a particularly difficult airway covering care techniques and best practice. It's my great pleasure to introduce our speaker, a truly expert in the field of airway management. Allow me to take a moment to introduce the remarkable career and achievement of our amazing speaker. Prof. Sheila Nainan Myatra is a professor of anesthesiology and critical care medicine who worked at Tata Memorial Hospital in Mumbai, India. Throughout her career, she has held various significant positions in critical care fields such as the chair of the Intensive and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiologists, and she is the past president of the Indian Society of Critical Care Medicine. She is also the past president of the All Indian Difficult Airway Association. In organization, Prof. Sheila is a member of the Surviving Service Campaign Research Committee and COVID Guideline Committee. She is one of the 14 international airway experts on the American Society of Anesthesiologists Difficult Airway Guideline and the project for the Universal Management of the Airway Guideline. Apologies in advance, Prof. Sheila is unable to attend due to an urgent concern. However, she will continue to present the schedule measure using the existing recording. Once again, I apologize for the inconvenience. Okay, for all the attendants, if you have anything to ask or discuss about the presentation, please share your question and throw in our chat column. And this question will be discussed after the all presentation. To the committee, please play the recording from Prof. Sheila.
Hello, everyone. I'm Sheila Myatra, Professor of Intensive Care working at the Tata Memorial Hospital in Mumbai in India. At the outset, I'd like to thank Professor Andriamuri and Professor Asep from the INSAIT for giving me the opportunity to speak at this webinar. It is indeed a great honor also to be invited to INSAIT 2024, which will be held in Medan. Unfortunately, I cannot be present in person, and I convey my very best wishes to the society for the grand success of this meeting. I'm going to be speaking to you about tracheal intubation in the critically ill patients with a physiologically difficult airway. Now, this is a recent paper that we published in Intensive Care Medicine. This was a global Delphi that we conducted on tracheal intubation in the critically ill adults with a physiologically difficult airway. And this was an international Delphi. And most of what I'm going to be talking about today is going to be based on this paper. And I urge you all to read the full text of this paper. Now, to give you a bit of background, let's talk about complications related to tracheal intubation in the intensive care unit. Now, if you look at complications in critically ill patients when you do a tracheal intubation, the number of complications are significantly high, whether it's hypoxia, hypotension, esophageal intubation, the aspiration or cardiac arrest, significantly higher than what you see in the operating room. Now, why are complications when you do tracheal intubation in the critically ill patients so high? Now, if you look at this patient, this study from the Intube study, which we published in JAMA in March 2021, And this was a global study on intubation practices and adverse peri-intubation events in critically ill patients from 29 countries. Now, most of the previous studies that I showed you were national audits or single center studies. This was the first global study that, an observational study of almost 3,000 patients that looked at how is intubation being done in critically ill patients and what was the rate of complications. This was published in JAMA 2021, and I was very fortunate to be the co-PI on this study. And this study involved 197 centers from 29 countries and 5 continents, almost 3,000 patients. And as you can see, Italy and India had the highest number of patients that were contributed. Now, the primary outcome of this study was to look at the occurrence of one of these complication events within 30 minutes of tracheal intubation, either severe hypoxia, cardiac arrest, and cardiovascular instability. So, which was, defined by the following criteria. So it was a composite endpoint of these 3 criteria. And at least one of the following events had to happen within 30 minutes, and that was the primary outcome of the study. And I won't go into details of the study, but I'd just like to tell you that if you look at the incidence of complications, which is the primary outcome, 45%, that means almost 1 in 2 patients in whom you do a tracheal intubation in ICU actually has an adverse events. And what was the surprising finding in this study was that unlike what we believe, it was not hypoxia, but cardiovascular instability, largely related to hypotension following tracheal intubation, that occurred in 42% of the patients. Again, almost 1 in 2 patients have hypotension following tracheal intubation. And severe hypoxia is about 9.3%, and cardiac arrest was about 3.1%. The other important finding of this study was this was the first study that looked at long-term outcome. So it looked at 28-day mortality. And what they found was that patients who experienced either an overall outcome or had cardiovascular instability or cardiac arrest actually had a higher risk of 28-day mortality. This means that the complications that occur during tracheal intubation actually have an impact on long-term outcome, on 28-day mortality. So most of the time we have some hypoxia, hypotension, and we just give some drugs, we try to correct it, we give oxygen. But if you have this complication, it actually increases the mortality. So we should try to prevent this rather than just treat these complications. So if you see the data from these studies, you would wonder that why are complications with tracheal intubation in ICU actually higher than what you see in the operating room? Now, I'm an anesthesiologist by background, and I still do some anesthesia work. I spend about 20% of my time doing anesthesia. So I'm in the perfect position to compare tracheal intubation in the operating room and in the intensive care unit in the same period of time. And in my mind, there are 3 differences, fundamental differences between tracheal intubation in the operating room and in the intensive care unit. Now, the first and most important is the ICU environment-related factors. The second is the operator factors. And the third most important are the patient factors, and I'll talk about each of them. Now, this is the ICU environment, and this is, I look at myself when I'm intubating a patient. Now, just look at, the environment in the intensive care unit. Just getting to the head end of the patient is such a struggle. Look at the things around the patient. There is my crash cart, there is my ultrasound machine, the ventilator. There's so much clutter. And this could be any time in the day or night. And I don't have the same help that I have in the operating room. I don't have all the tools in my armamentarium. This is a patient in septic shock. So I not only have to look after the airway, but I also have to look after the hemodynamic status of the patient. So the environment itself in the critical care unit makes increases the risk of complications during tracheal intubation. It's very well known that the intubation skills of the individual and the supervision makes a difference. Supervision during tracheal intubation by a senior or by an attending anesthesiologist, or even formal training in anesthesia, and juniors routinely supervised during the procedure. And you have studies to show that this can improve outcomes. So the experience of the operator also makes a difference to reduce the risk of complications. And the third and most important is the patient itself. Now, this is not the patient that comes fasted and completely optimized as they come in the operating room for surgery. And these patients often have an imbalance between oxygen delivery and consumption. So conditions like fever, sepsis, tachypnea, etc., increase the oxygen consumption, while low cardiac output, anemia, lung disease, and low FRC that are often seen in critically ill patients decrease the delivery. So these critically ill patients often have an imbalance because between oxygen delivery and consumption. And I'm sure you've all seen the Benioff curves. Now, when you look at a normal patient versus a patient who is critically ill, you can see that they already, and you look at the time to desaturation, and this is the time in minutes, and this is the oxygen saturation. And you can see that critically ill patients, they have a low FRC, high oxygen consumption, and you can see that they start with this already lower content of oxygen and they rapidly desaturate as compared to a lower, a normal patient during rapidly desaturated after apnea is initiated in these patients. And therefore, these patients are at a high risk for these complications. So these are the usual steps of tracheal intubation. You pre-oxygenate and they go up to the intubation. Now, as I mentioned, these patients have what we call a physiologically difficult airway, and this increases the incidence of complications like hypoxia and hypotension, and increasing the morbidity and mortality in these patients. And in addition to this, if they also have an anatomically difficult airway, then this further increases the risk of complications during tracheal intubation. Now, this term, physiologically difficult airway, was first coined by Gerard Mosier and John Sackers from the United States. Now, we always talk about anatomical difficulty. We are always obsessed with getting the tube in the trachea. But these patients have a physiologically difficult airway, and that means that the physiological alterations that occur in a patient who's critically ill, that increases the risk of cardiovascular collapse and other complications during airway management. Now, this is an emerging concept, this terminology first defined by John Sackers. And this, in this review article, which was published in Current Opinion, along with my colleague, Dr. Divatia, who's going to be the next speaker, we actually, defined, tried to extend what are the different, what a physiologically difficult airway actually constitutes in not only critical ill patients, but any patients who have, can have, because of their altered physiology, have an increased risk of complications. And this includes obese patients, obstetric patients, pediatric patients who have a shorter apnea time and increased risk of complications because of the altered physiology. And in this paper that I alluded to, which is published recently, we actually try to define this entity by consensus along with the global experts. Now, a little about this paper, and you can look at the geographical distribution of the experts, and it covers 35 experts from 15 countries and 6 continents, and these countries include low and high income countries. And I don't want to go into details, but we used a very robust Delphi process, and we looked at, we had iterative rounds, and the experts were anonymized to avoid any bias or group pressure. And we looked to achieve we tried to achieve maximum consensus and stability between the rounds. And finally, we had 54 statements that reached consensus and stability. And from these, 38 expert clinical practice statements were drafted. And I'll give you a highlight of these statements. So I really urge you to read this paper, because it's a very good paper that will give you a very good idea of the physiologically difficult airway. I'm just going to be giving you a snapshot. So these are the consensus statements that we drafted. The 38 consensus statements are put into very nice figures, which gives you a very good summary of these statements. So let's come to the definition. So what is the definition and the risk factor? So how we redefine physiologically difficult airway is, it is defined as one in which the patient's physiological and pathophysiological alterations increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. And these pathophysiological alterations, and this is hypoxia, cardiovascular instability, right ventricular failure, and increased intracranial pressure, as well as physiological alterations, as I mentioned, that occur in obesity and pregnancy, also constitute a physiologically difficult airway. And these environmental and human factors, in addition to the patient's physiological derangements, also contribute to an increased risk of complications. And the likelihood of encountering patients with a PDA is higher in the intensive care unit and emergency department as compared to other locations in the operating room. So this was a nice graphic where we talk about physiological alterations and pathophysiological alterations like cardiovascular instability, hypoxia, right ventricular failure, raised intracranial pressure, and all these conditions, when you do a tracheal intubation, the altered physiology itself can increase the risk of complications, and that is what a physiologically difficult airway constitutes. So obviously we have to have strategies to reduce these complications, because we know that these complications, if they occur, increase the risk of, high risk of mortality. So one of the most important thing is good preparation, team preparation and training. This is paramount, the use of checklists. It's important to have a team, and this team should have at least 3 healthcare workers, of which at least 2 should be airway operators. And among the airway operators, at least 1 should be experienced in airway management. It's really important to assign the roles and responsibilities to the team member. What is each team member going to do? Discuss the plan, discuss the rescue plan, and also, do this in advance and make sure you have all your equipment before you start. And training requirements for the providers is also really important, and simulation-based training should be part of the curriculum, is another thing that achieved consensus. So how do you prepare the patient and optimization? This is really important because they have physiological alterations. So airway assessment is important. And in critically ill patients, what the consensus was that they should be routinely undergo pre-procedural assessment using either the Makocha scoring system or the HIP scoring system, and they should be counseled about the airway management prior to tracheal intubation. Of course, this is not feasible at all times. The patient may be comatose or the patient may not be cooperative, but if possible, they should be counseled about their tracheal intubation. And this is the Makocha scoring system. And, this is a very nice scoring system that can be used in validated in critically ill patients. It's a 12-point scoring system. And what is really beautiful about, there's a mnemonic for which Makocha, it's Malampati, apnea, cervical spine, mouth opening, coma, hypoxia, and anesthesiologist non-trained. And what's the beauty of this scoring system is that it not only looks at anatomical factors, but it also looks at physiological factors. For example, factors related to pathology like coma, severe hypoxia also get an additional point. And it also looks at the experience of the operator. For example, if you're a non-anesthesiologist, you get 1 additional point. And this further increases the risk score for complications during the tracheal intubation. So Makocha scoring system is a scoring system that's validated and that you could use. The patient's position is very important. Now, the consensus was for using the HELP position or the head elevated laryngoscopic position. And this head elevation is about 20 degrees. And why do we give this head elevation? Not only for pre-oxygenation, but also for tracheal intubation. Firstly, this is more comfortable for the patients because they can take in more full breaths. And if you keep the patient absolutely flat, then the posterior portions of the lung, they become more prone to atelectasis and collapse. And that's what we don't want. And you could try to align the external auditory meatus with the suprasternal notch, especially in very obese patients, this could be done. And you could make the patient's face parallel to the ceiling. So this is the kind of way in which you can keep the patient in the head elevated laryngoscopic position rather than keep the patient absolutely fat. Now, we talked about a 9% incidence of complications, respiratory complications and hypoxia in the INTUBE study. So oxygenation and respiratory optimization is paramount, and the pre-oxygenation and continuing nasal oxygen during attempts at securing a tube is very important. And the apneic oxygenation and pre-oxygenation, there are different techniques. We have the conventional oxygen therapy, and then we have non-invasive ventilation that we can give, giving pressure support and PEEP during pre-oxygenation, or we can even use hydronasal oxygen in patients with physiologically difficult airway. Now, I'm sure you have seen this recent study that was published in the NEJM, and this is the non-invasive ventilation for pre-oxygenation during emergency intubation. And this was a study that compared NIV with the conventional oxygen therapy for pre-oxygenation. And the primary outcome of the study was hypoxia during tracheal intubation. You can see it was 9% versus 18%, almost 50% reduction when you use NIV. And the conclusion of the study was among critically ill adults undergoing tracheal intubation, pre-oxygenation with NIV resulted in low incidence of hypoxia during tracheal intubation and pre-oxygenation with an oxygen mask. And this is probably because of the, the ability to deliver PEEP as compared to conventional oxygen therapy when you use NIV. And this is probably helping in those patients who had a high risk of desaturation. Then there is the Florali study. This is the first Florali 2 study, and this is a French multicenter study that has actually compared non-invasive ventilation with high flow nasal oxygen for pre-oxygenation during tracheal intubation in the intensive care unit. And what were the results of this study? The primary endpoint of this study was to look at the incidence of saturation going less than 80% during tracheal intubation. And if you see between NIV and high flow nasal oxygen cannula, if you see the p-value, there was really no difference in the primary endpoint. However, what is interesting, in the subgroup of patients who had the PaO2 FiO2 ratio less than 200, non-invasive ventilation was superior as pre-oxygenation as compared to high flow nasal oxygen. And then you know about this other landmark trial, which was again published in NECM, where they gave bag mask ventilation during tracheal intubation in critically ill adults. Now, as you know, conventionally, we do not give bag mask ventilation during rapid sequence intubation because there's always a perceived risk of aspiration. Critically ill patients are also considered as full stomach because of the critical illness and gastroparesis that is associated with the critical illness. They may be diabetic, they may have other conditions that increase risk of aspiration. So they're considered as full stomach, and that's why we do a rapid sequence intubation. However, if you see these patients who come with ARDS, pneumonia, etc., have at a very high risk of desaturation and hypoxia during tracheal intubation. So we have to really look at a risk-benefit ratio. And what they did in this study in NECM is in those patients who were not at a very high risk of aspiration, they actually gave gentle mask ventilation during a rapid sequence intubation. And if you see the comparison between the two groups where they gave bag mask ventilation and no ventilation, there was a significant decrease in the lowest, oxygen saturation incidence in patients who got bag mask ventilation. Of course, this study was not powered for aspiration. If you had to look at a study with aspiration as the primary endpoint, you would need thousands of patients. But the good thing is that there was no increased risk of increased aspiration in those patients who gave, in whom gentle mask ventilation was given. So this study definitely gives us more confidence to use bag mask ventilation, especially in those patients during RSI, especially in those patients who are at a high risk of desaturation. And this was a very nice, cartoon image that we made summarizing in, non-invasive respiratory support before and after mechanical ventilation. And this was published in Intensive Care Medicine. And this is an editorial that we wrote. And I will, of course, focus on the intubation part and just summarizing the current evidence with, oxygenation and peri-intubation oxygenation. And definitely pre-oxygenation with NIV is superior to high flow nasal oxygen, as you have seen in the Florali 2 trial, when there is moderate to severe hypoxia, that is the PaO2 FiO2 ratio is less than 200. We should continue with apneic oxygenation, that is give nasal oxygen during attempts at intubation. And gentle mask ventilation can be used, especially in those patients who are at a high risk of desaturation. This is the current evidence summary of use of oxygenation and apneic oxygenation. There's, I don't know, we talk about rapid sequence intubation. I don't know how many of you have heard about delayed sequence intubation. There's a very elegant paper that comes from India. It's the first randomized controlled trial comparing delayed sequence intubation with just, conventional rapid sequence intubation. Now, delayed sequence intubation was first coined by Scott Weingart from the United States. And it was proposed. And what do you mean by delayed sequence intubation? And, a lot of times these patients come very rowdy, very hypoxic, and it's very, very difficult to oxygenate them. And they need it the most, but it's very challenging to do this. So what we tend to do is we just tend to induce them very rapidly and intubate them. And as a result, they don't get good pre-oxygenation and they're a high risk for a hypoxia. A delayed sequence intubation means giving a very low dose of ketamine, about 1 milligram per kg to these patients. And when you give this ketamine to the patients, they get sedated, they become more cooperative. You can actually make them lie flat. You can pre-oxygenate them very well. And, sometimes after doing a DSI, these patients may not even need intubation. And then you can proceed, if at all they need intubation, to doing a rapid sequence intubation. So you're pre-oxygenating them well. So this study, as you can see, when they looked at the oxygen saturation at various time points, it was, significantly better in those patients who got the delayed sequence intubation. It's very underutilized technique in the intensive care unit, used a lot in emergency medicine. We should try to use more and more of delayed sequence intubation in our critically ill patients. Hemodynamic monitoring is very important. As you saw in the INTUBE study, 42% patients had hypotension. following tracheal intubation. That's almost 1 in 2 intubations, the patient has hypotension. So it's not hypoxia that we were always worried about, but hypotension that occurs more commonly. Probably over time, we have become very good at peri-intubation oxygenation, and we are not recognizing that it is hypotension that is the most commonly seen complication, and we need to do something about this. So monitoring these patients is very important, and hemodynamic optimization prior to tracheal intubation is very important. And even you can use things like point of care ultrasound, etc., whenever feasible, to use the safety to improve the safety during tracheal intubation. Now, why do patients get hypotension following tracheal intubation? Now, one of the reasons could be the critical illness itself, sepsis, hypovolemia, etc. Then the various drugs that we use for tracheal intubation, like propofol, benzodiazepine, the loss of sympathetic drive. So a lot of times these patients have high blood pressure, they have tachycardia, and this gives you a false sense of security because you think the blood pressure is okay, and it is just the sympathetic drive that is keeping the blood pressure and the heart rate up. And the moment you anesthetize them, they have precipitous fall in blood pressure. And the other reason why they can get hypotension is the positive pressure ventilation that is given, especially in patients who are hypovolemic, because when you give positive pressure ventilation, you increase the intrathoracic pressure, you decrease the venous return, and then you further decrease the cardiac output. So all these factors can cause hypotension in these patients, and it's really important to optimize them. So what is the conventional strategy that we've been using? We've been giving fluid bolus prior to tracheal intubation. And this was also part of the intubation bundle, but it had never been tested prospectively in a randomized controlled trial. And this is what the group from Vanderbilt did. They did a randomized controlled trial comparing giving a fluid bolus prior to tracheal intubation, one group, and they used 337 patients. And in the other group, they did usual care. And the primary endpoint was looking at the incidence of cardiovascular collapse. And what was very interesting is that intravenous fluid bolus did not decrease the overall incidence of cardiovascular collapse compared to no fluid bolus. And that was a very surprise finding. But it is very interesting because in a subgroup of patients in whom they gave positive pressure ventilation, for example, those who got NIV or high flow nasal oxygen or who received bag mask ventilation during RSI, there was a benefit of giving fluids. So the same group conducted another study called the PREPARE-2 study. And here they took only those patients who underwent positive pressure ventilation, and then they gave them either a fluid bolus or no fluid bolus. And interestingly, there was no difference in the incidence of cardiovascular collapse between the two groups. So it's very interesting because the incidence of hypotension is 42%. It's real. It's 1 in 2 patients. The incidence is very high. And fluid bolus, which we've been using conventionally, doesn't seem to be working. Of course, there are limitations in both these studies. I won't discuss them in the interest of time. So perhaps there is a role. You have high incidence of complications. Fluid don't seem to be working. So perhaps there is a role of using a low dose of vasopressor, given to prevent the hypotension rather than to treat it as we are doing today. And there are 2 trials underway to test this. One is the FLUA trial, which is being conducted in our unit at Tata Memorial Hospital. It's just been completed and we are analyzing the data. And here we are giving low dose of vasopressors, about 0.08 microgram per kg per minute, given through a peripheral dyne 10 minutes before tracheal intubation as an infusion, and compared with a fluid bolus, and then looking at the incidence of cardiovascular collapse and seeing whether this low dose can prevent the incidence. And the second study is the prevention trial. And this is a study that is, I'm also a part of the steering committee, and this is being done by the European Society of Intensive Care Medicine through a grant. And it's a multi-center study. And here they are comparing a low dose of vasopressor and they're using norepinephrine along with usual care. So the results of these trials will actually tell us whether there is a role of giving low dose of vasopressors. Performing the procedure is very important. And, we use by default a modified rapid sequence intubation. The medications that we give are either ketamine or etomidate because we are always worried about the hypotension that can occur. So we use relatively cardiostable drugs. A video laryngoscope should be used, as the default technique because we've already seen that it increases first pass intubation success, and we should use a stylet or a bougie along with the video laryngoscopy because the video laryngoscope will give you a great view, but delivery of the tube is really very important. Now, ketamine or etomidate are the most commonly used induction agents, and there have been several studies, and now we have a meta-analysis, and this is done in critically ill patients who underwent tracheal intubation, and this is a Bayesian meta-analysis. And if you look at the results of this Bayesian meta-analysis, they actually found a moderate probability that induction with ketamine compared to etomidate for tracheal intubation was associated with improved survival in critically ill patients. But in clinical practice, you can use either of the drugs They're both cardiostable and will reduce the incidence of complications. Now, I told you about the high incidence of complications, cardiovascular collapse in the INTUBE study. We did a subgroup analysis. We did an analysis of the patients who had cardiovascular collapse in that study, and we did a logistic regression to find out that what were the characteristics that were associated with hypotension. And it was very interesting because there were different variables, and among the modifiable variables, it was propofol that was independently associated with transitioning into hypotension. So the conclusion of that paper was that, of course, the cardiovascular instability incidence is very high, and this increases the risk incidence of ICU and 28-day mortality. And the use of propofol for induction was identified as a modifiable intervention significantly associated with cardiovascular collapse. So this means we shouldn't be using propofol for tracheal intubation, and this is irrespective of the starting blood pressure. As I mentioned, that the sympathetic drive can often keep the blood pressure up, and once you give propofol into these patients, you can have precipitous fall in the blood pressure. Now, of course, we have to do RSI. Now, whether you give neuromuscular blockade, people are worried to give neuromuscular blockade, especially those who are not anesthesiologists. But you can see when you look at the incidence of complications, the use of neuromuscular blockade actually reduces the incidence of complications. Now, which neuromuscular blockade should you use? Choline or succinylcholine rocuronium? Well, you can use either of them. No difference in this study in terms of first-pass intubation success, CL grade or POGO scoring. But remember, when you use rocuronium, you have to use little higher doses if you wanted to use it for RSI. And if you want the effect to come in 60 seconds, you have to give at least 1.2 milligram per kg dose. Now, there's no doubt that video laryngoscopy is superior to direct laryngoscopy in critically ill patients. And this is from the NEGM paper that has been the device trial that has been published. And you can see a clear separation and a benefit of patients with video laryngoscopy as compared to critically ill patients, in which direct laryngoscopy was used. And the conclusion of this paper was among critically ill patients undergoing tracheal intubation in the emergency department ICU, the use of video laryngoscopy resulted in the higher incidence of successful intubation on first attempt than the use of direct laryngoscopy. So we should be using video laryngoscopy. Every ICU should have a video laryngoscope with people trained to use it. And don't use it when your direct laryngoscopy fails, but use it even in normal airways so that you can be experienced to use it when you actually face a difficult intubation. Post-intubation care is very important. The use of capnography is really important, and using low tidal volume ventilation and monitoring the patient. And here I'll talk a bit about capnography. Now, this is the consensus guidelines that were published by the in anesthesia on preventing unrecognized esophageal intubation. And this was a consensus from the PUMA group, and I'm very proud to be a member of this group. And the key recommendations for this was use end-tidal carbon dioxide and pulse oximetry should be immediately available, and use routine laryngoscopy. And we've given a very nice graphic over here. And here you can see that whenever you have put the tube in, you should look for consistent waveform capnography, at least 7 breaths. Sometimes, and it should either be increasing amplitude like this, but not something like this where there's decreasing amplitude. Excuse me. You may have a tube that's in the esophagus, and there might be a lot of air in the stomach. Initially, you might see some end-tidal CO2, but over the next few breaths, it will decline. So it's really, really important that you don't react to one trace of capnography. Look for consistent waveform capnography with no decline before you confirm tracheal intubation. It's really, really important to use capnography in the intensive care unit. Now, again, another interesting finding of the INTUBE study was that video laryngoscopy was used only in 17% of the patients. And this was not because video laryngoscopy was not available. This was also the story in the developed world, which actually shows very low utilization. And probably after the results of the device study, the incidence of use of individual laryngoscopy will increase. And another surprise finding was people were using 60%, almost close to 60%, are still using auscultation to confirm tracheal intubation, whereas waveform capnography was used only in 1 in 4, but 25% of the people. So we really have a long way to go, because we know that not using capnography can increase to confirm tracheal intubation, increases the morbidity and mortality following tracheal intubation. So this is a very nice graphic from our paper, and I urge you to read the paper, which summarizes the definition of physiologically difficult airway, where they commonly occur, which is in the intensive care unit emergency department. And what it means is that, these patients have an increased risk of complications during tracheal intubation and transition to positive pressure ventilation. And we've highlighted the importance of treatment preparation, the patient preparation, the drugs, the RSI, and various aspects of the tracheal intubation, and of course, the post-intubation care. Now, guidelines are very important. I'm very proud to be, for this guideline on tracheal intubation in intensive care unit. The first guideline comes from India and from the All India Difficult Airway Association. We are currently updating this guideline. And subsequently, we had, this is what the algorithm for the Indian guideline looks at. Subsequently, we had the French guidelines that looks at tracheal intubation and extubation in the intensive care unit. And this was followed by the Difficult Airway Society guidelines. So in 2 years, we had 3 guidelines looking at tracheal intubation in ICU. That means they're actually emphasizing that these patients have, need some special consideration because they have a physiologically difficult airway. And it's not only the anatomical difficulty on passing the tube, but also various physiological considerations that I've outlined that need to be taken into consideration. So I'd like to conclude my talk by saying that the physiologically difficult airway is one in which these physiological and pathophysiological alterations in the patient increase the risk of complications and transition to positive pressure ventilation. And as you have seen, hypotension and hypoxia are the most common complications. And among them, the hypotension is really the most common one, occurring in almost 42% of the patients. And these patients who have complications actually have a higher risk of 28-day mortality. So we should not take it lightly because these, the small complications that occurs, which you could take care of during a tracheal intubation actually has an impact on long-term outcomes. And therefore, we should do everything to prevent these complications. And we should use strategies outlined to help to reduce these complications, which I've already talked to you about. And what's most important is tracheal intubation is actually a life-saving procedure, but this can turn into a life-threatening situation if it is not managed appropriately. And with that, I thank you very much for your attention. I'll leave you with the definition of physiologically difficult airway, which includes pathophysiological alterations, these 4, and physiologically of the alteration, and that is, these are the constituents of a physiologically difficult airway. And with that, I thank you very much for your attention.
Okay, now we are call the second speaker is Professor G.V. Divatia, who will be sharing their expertise on the management of the difficult airway. Professor G.V. Divatia is a professor and head Department of Anesthesiology, Critical Care and Pain at the Tata Memorial Hospital, Mumbai, India. He has held a very significant position in anesthesiology and critical fields such as President, Indian Society of Anesthesiologists, Past President, Indian Society of Critical Care Medicine, Editor-in-Chief Airway, as an official journal of the All Indian Difficult Airway Association, Past Editor-in-Chief Indian Journal of Anesthesia, over 200 publications in national and international journal, presentation in several international, national, and state conference. Without further ado, I would like to invite to Prof. G.V. Divatia to deliver the insightful presentation in 25 minutes. Please, Prof. Divatia, time is yours.
Yeah. Good afternoon. Thank you, Professor Andriamuri, for inviting me to speak here at the webinar and for the invitation to your conference in Medan. I really look forward to meeting you next week, all of you. So thank you very much. Okay, so let me start about the management of the difficult anesthesia. We've already heard a very nice talk from Dr. Sheila on management in the intensive care unit, in the critical patient. We'll talk about anesthesia. Now, when I was training in anesthesia many years ago, we used to give thiopentone, used to give succinylcholine, face mask, and try and intubate. And if we could not, then you'd get someone to help you. Then maybe you'd try an airway to get ventilation going, and then maybe that person would try to put in a tube, maybe with a stillet, with a bougie. They tried multiple attempts, they would do all sorts of things. And that was the only option. And then maybe a tracheostomy, call a surgeon in desperation. And at the end of it, if you couldn't do anything, you just prayed and hoped everything went well. So that was all we could do. So we didn't have too many options 40 years ago. But today we are living in a different world. And we've got so many new gadgets, so many new advances in airway management. And I'll take you through some of them because they are extremely important and they've made airway management much safer, and they give us many more options to use when we are managing the difficult airway, right? So what do we mean by a difficult airway? This is a traditional definition, which is there in the ASA guidelines, which have been released last year, 2 years back. It's a situation anticipated or anticipated where you, a reasonably trained anesthetist, would have problem with mask ventilation, laryngoscopy, supraglottic airway, intubation, extubation, or invasive airway. We heard from the last talk, we also now have the concept of physiologically difficult airway, which not only applies in critically ill patients, but maybe even in pregnant patients, okay, maybe in obese patients, in children. And just a small disclaimer, all my talk is restricted to adults because I don't do pediatrics, but yes, children also have a physiologically difficult airway. So, so you can have physiological difficulty as well. And we need to keep that physiological aspect in mind whenever we have a anatomical difficulty as well. So now the whole problem with difficult is because of us. We pre-oxygenate, we induce now with propofol or something, we give a muscle relaxant, right? And we give a muscle relaxant only to make our life easy, so that our intubation, laryngoscopy and intubation becomes easy. We give a muscle relaxant, the patient becomes apneic, and then there is no oxygen going to the patient, right? And in the period before and during the period that we get the tube in and restore ventilation, the patient is not breathing. And if for some reason we are not able to get the tube in on time, or we are not able to deliver oxygen to the patient, either by face mask or by intubation, then we say, this patient can have a problem and he will suffer from hypoxia or brain damage or something like that. So it is very important that during the apneic period, there is a safe apnea interval, and before the patient starts desaturating, we should be able to either ventilate the patient by some means, or we should get the tube in and be able to ventilate the patient by endotracheal tube. And the difficulty is when we can't do any of these things, and then we are in danger of hypoxic brain damage or death. Now, today, like I said, we've got devices, tools, and techniques which make management of the difficult airway much simpler and much safer. So one of the most important advances in airway management actually occurred long back in the 80s, and that was the supraortic airway, the laryngeal mask. And that made life much simpler because, you could, even if you could not intubate, you could get the laryngeal mask in very rapidly. It was not very difficult at all. And even if you had difficult ventilation or difficulty in holding a face mask, the laryngeal mask would actually go in very often, and you would be able to stop ventilation. And then you could save the patient and that sort of thing. You could also use the laryngeal mask as a conduit through which you could put an endotracheal tube. Of course, the success rates are variable, and you could even give anesthesia using the laryngeal mask. And the only problem with laryngeal mask was, it did not have a tight fit. There was no tight seal, and you could get a leak with high pressures of ventilation, which could happen with obese patients, pregnant patients, or the patient had bronchospasm. You could not give very high airway pressures. And of course, if your mask did not sit properly, then of course you would have a problem and not be able to ventilate. Okay. And therefore, because it was not a tight seal, the risk of aspiration always remained with the laryngeal mask. Now, today we've got better laryngeal masks, right? We've got the second generation devices like the Pro Seal or the Supreme, or many of the Ambu Aura Gain, many other second generation devices are there, and they are designed to reduce the risk of aspiration. They've got, they've got a gastric tube and they've got an airway tube. So you've got a gastric drain tube and an airway tube. You sort of and you've got two cuffs, right? So you have some separation of the airway and the alimentary tracts. Okay? And because of these cuffs and these features, you can actually give a higher airway pressure. So about 30 centimeters of water, positive pressure ventilation is well tolerated without a leak. And so these tend to be safer than the first generation devices. So today, if you're going to use a laryngeal mask, you're going to use one of the second generation devices. And like I said, there are many different devices. We won't go into all of them. In India, at least, the iGel and the Ambu and the ProSeal are quite commonly used. We've got new ones like the Protector. You've got the LMA Gastro, through which you can even do an endoscopy. Okay. So all these things are there, and they've made, so the suprachoroidal devices are extremely important. And then there's one more device now called the Bhaska mask, which increases the seal with IPPV. So when you give IPPV, this cuff sort of further seals the trachea around the larynx, and you can get even higher IPPV pressures are tolerated. So these are all designed to improve positive pressure ventilation and avoid aspiration. Having said that, the risk of aspiration with these masks is generally quite low in practice. And now today we are using the laryngeal mask for a wide variety of indications, but it is extremely useful as a rescue device in case you're not able to mask ventilate the patient, or if you're not able to intubate the patient, you can use the laryngeal mask. Laryngoscopy, for many years we were stuck with a direct laryngoscope, but today we've got video laryngoscopes. And that's another big innovation that has changed the way we intubate patients, and again made life much simpler. And again, they have a camera at the end in the laryngoscope blade, and they give you a fantastic view of the larynx. And the important thing is, you need not align, you don't have to give the intubating position, because uh, the camera is right here at the tip, and you get a very good view of the larynx. The problem, and you have different types of laryngoscope. I'm not going to go into all the different types of video laryngoscope, but essentially you've got channeled or non-channeled blades, and you've got the Macintosh type blades, or you've got the hyperangulated blades, which are actually very useful for a very anterior larynx or a very difficult intubation. And you've got screens which are either on the handle or which are located away from the patient. And so you can get a very good view of all these sorts of things. The only thing that we need to learn during video laryngoscopy is you have a fantastic view of the larynx, but you still have to negotiate the curves of the pharynx, oral cavity and pharynx to get the endotracheal tube in. So like initially we used to say, the laryngoscopy is easy, but getting the tube in is a little difficult. But now we realize that especially the hyperangulated blades, you must use a shaped stillet to overcome the curves of the oral cavity and pharynx, and then you can easily intubate the trachea. So although the view is very good, you still need a bit of training and expertise to get the tube into the trachea. But apart from that, it has made intubation much, much simpler. Okay. And as there are multiple studies and trials which have been done, and they all are virtually unanimous that, with video laryngoscopy, the rates of failed intubation come down dramatically. So almost the risk ratio is 0.4, so 60% reduction in failed intubation, increased success rates of first attempt, and all those sorts of things. So there is no doubt today that video laryngoscopy has made intubation much simpler, and success rate has dramatically increased, and the rates of failed intubation have come down. Now, so like I said, all these things were the traditional anatomically difficult airway. We've been introduced now to the concept of physiologically difficult airway in the period of apnea. And the other thing which makes airway management difficult is the risk of aspiration. So especially when you've got pregnant women, or you've got patients coming with trauma or in an emergency with a full stomach, then you need to make sure that the aspiration risk is significantly reduced. Now, again, you do get desaturation during apnea, and you can see that a normal adult will tolerate about 8-9 minutes of apnea easily after pre-oxygenation. But if you've got an obese person, it's just less than 3 minutes, right? And if it's an obese pregnant woman, it could be less than a minute. So these are patients who, even if they have a simple airway, even if they don't have a very difficult airway, just the fact that you've got only 1 minute in which you can safely intubate the patient without the saturation dropping, it makes the airway a little difficult. And it is not, especially if you're a beginner, or if and you're doing one of these cases, then you are a little bit under stress, and you need to be sure that you prevent desaturation during apnea, especially in these high-risk patients. And the simple ways of preventing desaturation during this apneic interval is to give apneic oxygenation. And one of the simple very important, right? that is, high flow nasal oxygen, 100% oxygen. And this THRIVE stands for transnasal humid rapid insufflation ventilatory exchange. And, it's so 70 liters flow. And because you're giving 70 liters flow, you need a fantastic humidifier, which is built into the system. And, so that your nasal, otherwise, if you give 70 liters of dry oxygen, it'll slough off your nasal mucosa. So you need that humidifier to work very well. And, you can use high flow nasal oxygen for pre-oxygenation, and very importantly, use it during the apneic interval when you're doing your laryngoscopy, and that will dramatically increase the safe apnea interval. And as you can see in this very important study by Dr. Anil Patel, one of the first studies which promoted high, high flow nasal oxygen or THRIVE, is you can see the median time for apnea was very good. Extend the safe duration of apnea when the saturation stayed above 90% was 20 minutes. Okay, so instead of 5 to 8 minutes of safe apnea time that you now have 20 minutes. In 20 minutes, also, if you're not able to intubate the patient, you have 20 minutes. You can call for help. Someone can come in from either from the next OT or even from the next building, or someone can even quickly drive a car and get there. But you've got 15 to 20 minutes in which you can get help, get all your things together, get the team in place, get your equipment in place. So it makes life safer, right? And in some patient, they went to 40 minutes, and one patient even went beyond 60 minutes of apnea time. So that's an amazing sort of thing that you have got to, but remember, you must give high flow nasal oxygen from the beginning. You should not start when you fail, when you made 2 or 3 attempts, already the patient started desaturating. That's not a time to start high flow nasal oxygen. You should start it right from the beginning when your functional residual capacity will be filled with oxygen, and you just keep topping it up with nasal oxygen. With THRIVE, it's during the apneic period, there is some ventilation which goes on. The mechanisms we can debate and discuss, but it's not just in a normal apneic oxygenation, with the low flow oxygen, the CO2 rises by 3 to 6 millimeters of mercury per minute. But with high flow nasal oxygen, in this study, the rise was only about 1.15 millimeters of mercury per minute. So you can, in 20 minutes, the CO2 will go up by only about 20 or 25 millimeters of mercury. So that's another big advantage of THRIVE. We must confirm intubation with capnography. I think that has been a standard message, and this is from the PUMA guideline, which says that you must observe at least 6 rising or constant traces on the capnogram, and there is no other method to confirm tracheal placement of your endotracheal tube. You must have a capnogram, and there is no debate on that sort of thing. Okay, and because even if and using the video laryngoscope also makes it important because you can have someone else confirming that the tube is in place. So with a video laryngoscope and a capnogram, the incidence of unrecognized esophageal intubation can come down dramatically. The last sort of innovation which is there is, we can reverse neuromuscular block, especially if we're using rocuronium or maybe even vecuronium. Can use Sucamadex to reverse the block, and the patient can come out of anesthesia very fast, and the muscle relaxation is reversed. And it can, if you give the full dose of 16 milligram per kilo of Sucamadex, you can reverse the rocuronium block in just a little over 1 minute. So that also is an advantage. You can get the patient out of muscle relaxation, breathing spontaneously, and reduce the risk of hypoxia. So these are all the innovations that have come in, which have made airway management safer. Now the question is, what strategy do we have to use all these things in our practice to make patients airway management safer? So there are some patients who are obviously challenging airways. You see them and you know that it's going to be a difficult airway. Okay, and then of course you've got patients at high risk of aspiration, those who are potentially obstructed, and those who have difficulty even with an invasive airway, like someone like this or someone with a Ludwig's angina will be even an invasive airway will be difficult. So we need to have strategies to tackle these airways. Now, risk of aspiration has always been a problem, and we used to always say so many hours fasting, and if the patient is not fasting for 2 hours or 4 hours or 6 hours, arbitrary time intervals we've said. But today with gastric ultrasound, we can actually see what is the content, what is the status of the stomach contents. You could either make sure that the patient has an empty stomach. You can see this is a gastric ultrasound, this is the liver. This is how you put the probe in the lateral position. And so here is the antrum, this is the liver, and this is the aorta. So this is the gastric antrum, which is empty. This is an antrum which is filled with solid, but a little late. So and this is a solid which is early. So you've got this sort of appearance over here. And this is a liquid in the stomach, in the antrum. So you can sort of make out, and you can use measurements to estimate the amount of fluid in the stomach. And so that can tell you the risk of aspiration. So you don't have to guess. You can actually see what is the stomach content and then decide what is the risk of aspiration. So now today in patients with the risk of aspiration, we do what we call as a rapid sequence induction. And that also has changed over time. And today our rapid sequence intubation is, we reoxygenate, of course, to get end tidal oxygen of 90%. Then you give titrated doses of your induction agent. Start high flow nasal oxygen, right? If you don't have Thrive, then you give nasal oxygen at 15 liters per minute, but otherwise you give Thrive. Okay. Once you lose consciousness, you give cricoid pressure, but today the emphasis on cricoid pressure has reduced. If the intubation is difficult, if laryngoscopy is difficult, we can release cricoid pressure. It is recommended you release the cricoid pressure. Okay. During the period of apnea, give gentle IPPV. Earlier, we used to not give IPPV, but today say you can give up to 20 centimeters of water, gentle IPPV, right? Continue Thrive, and then put in the endotracheal tube, use of video laryngoscope. Okay. Can we predict difficult intubation? Lots of tests, but one of the tests which has been evaluated and found to be very predictive with a high degree of specificity and specificity is the upper lip bite test. So if you are not able to get your lower teeth above your upper teeth, then that predicts difficult intubation in a significant proportion of patients. So if this is positive, it works. We will have artificial intelligence very soon. Just by taking pictures of the patient, we'll identify difficult airway. Of course, this depends on the database. So if you use a database or an artificial intelligence tool based on American white patients, that may not be very useful in, say, Indian patients or maybe even in Indonesian patients, because you'll need your own database and your own features to predict, that to match the database for difficult airway. But this is something which is going to come up very soon, and all of us will have some use to that sort of thing. So if you have a predicted difficult airway, what should you do? Right now, this is the ASA difficult airway algorithm. It tells you that if you suspect difficult intubation or with laryngoscope, and you suspect difficult face mask ventilation or supraortic airway, and maybe there is a risk of aspiration or a risk of rapid desaturation, like with a physiologically difficult airway. So if multiple risk factors are present, you should probably go in for an awake intubation. Okay. Otherwise, if there are no risk factors, then, or just one risk factor, maybe you can try under general anesthesia. But you need to decide whether to do an awake intubation or not. And many of us are reluctant to do awake intubation, but awake intubation is also now much simpler. We've got very nice airway anesthetic techniques. We've got video laryngoscopes, which don't need as much anesthesia. We've got fiber optic bronchoscope, right? But even when you're doing an awake intubation, you need to have a backup plan of what will you do if you fail with an awake intubation, right? And either you do different types of awake techniques, or you take a calculated risk and do an invasive airway, or you do a invasive airway, or you take a calculated risk and give general anesthesia, right? But you should have a different array of awake techniques, which we should all be familiar with. Of course, the bronchoscope is the #1 technique, right? The flexible bronchoscope is the best sort of technique, but you need to be able to do a awake video laryngoscopy, maybe even awake direct laryngoscopy, or you could do something like a hybrid technique, awake video laryngoscope plus a fiber optic bronchoscope. So fiber optic bronchoscope, you can see inside, but you can't see what's happening outside the fiber optic scope. So that you can do with the video laryngoscope. So you will have hybrid technique, right? And then you can do retrograde techniques, retrograde intubation. That someone in many parts of our country, if a fiber optic is not available, we can do a retrograde sort of intubation. Or of course, you can do an awake invasive way with a tracheostomy or trachothyrotomy. The Difficult Airway Society has got very nice guidelines for awake tracheal intubation. I would recommend that all of you read that, and it tells you how to, the steps, and very importantly, you must oxygenate either with high nasal oxygen or standard nasal oxygen, even in an awake technique. Give good topical anesthesia. And of course, they emphasize on spray. Perform the technique properly, and you must all be familiar. I'm sure in your workshops, which you will have next week, there will be lots of skill stations which will tell you how to do a good fiber optic intubation. And of course, you should sedation if required. I prefer to do all my awake intubations awake without much, but you've got rapidly reversible agents like remifentanil, that's excellent. Okay, we use dexmedetomidine in our country. Remifentanil has very recently become available, so I think we'll be using it much more in future. Some people talk of a double setup where, you know, really potentially difficult airway, you dissect do a incision and dissect up to the trachea, but don't do the tracheostomy. Okay, give general anesthesia, try to put in the tube. If you find it difficult, then immediately go and open the trachea because you already dissected up to the trachea, do the tracheostomy and save the patient. In our hospital, we do something slightly different. It's like the double technique, but instead of doing a dissection, surgical dissection, we put in a cannula in the cricothyroid membrane in the awake situation, right? Then we give general anesthesia. If the airway is very difficult, then we just give ventilation, jet ventilation through the cricothyroid cannula, and then, you know, do the rest of the procedure. So that's another thing that can be done. And you can use ultrasound to locate the cricothyroid membrane and accurately position your cannula into the cricothyroid membrane. Okay, now we come to the unexpected difficult intubation. There are times all of us have faced that, you know, that you're trying everything and the patient is desaturating, and essentially we must try and prevent this situation. We can't have a situation where the patient is desperately hypoxic. You know, the patient's heart rate, pulse rate is 29 and your heart rate is 229, and, you know, all those sort of things are happening. So there are guidelines for this, right? The common guidelines a lot of people use are the British Difficult Airway Society guidelines. You have the American algorithm of the ASA Difficult Airway algorithm, which is, you know, quite confusing. There's so many branches, right, left, up, down. But it's a very elaborate sort of thing. If you read it thoroughly, you get a very good idea of what to do. And then we've got our own guidelines from the All India Difficult Airway Association. Dr. Sheila talked about the guidelines for the intensive care unit. We've got guidelines for unanticipated difficult airway in adults. In fact, we brought out guidelines for unanticipated difficult airway in adults, in children, in obstetrics, difficult for extubation, and of course for the intensive care unit. So I'll just speak a little bit about our guidelines. You know, so what is different in our guidelines? You know, many people say you just copied and pasted from 2-3 guidelines, but there are some unique features of the Indian guidelines. So one is we stress the importance of oxygenation. The British guidelines say you must have 3 attempts at intubation. We can keep arguing whether you should have 2 attempts, 3 attempts, or 5 attempts. But we say that you should stop trying to intubate if the saturation falls below 95%. If it falls below 95, even if it's after 1 or 2 attempts, start ventilating with a face mask, restore oxygenation, and try again. Okay, we recommend that nasal oxygen be given throughout the apneic interval, at least 15 liters of oxygen. And if Thrive is present, use high flow nasal oxygen. Now, a lot of people say, you know, cannot intubate, cannot oxygenate, CICO. And we don't know what is cannot oxygenate. The cannot oxygenate is a very difficult term. Some people think it means that only if the patient becomes hypoxic that you should resort to the next step. But I think cannot oxygenate means the way we normally do things, failure to ventilate precedes failure to oxygenation. So if you're not able to ventilate either by face mask or by laryngeal mask, and you're not able to tube in, then you have a situation which we call as complete ventilation failure. And that eventually leads to hypoxia. So we say we define complete ventilation failure, and, you know, and that is the time you move to maybe a cricothyrotomy. Not when the oxygen drops, but when you're not able to ventilate by any means. Okay. So this is our algorithm. It's a stepwise thing. So the first step is, you know, you try and you can't intubate. So the first step, you call for help, right? So if we see this call for help goes all along the algorithm. And then you confirm with capnography. If you can't do that, so we say maximum 2 attempts, repeat only if saturation is more than 95%, give nasal oxygen, optimize position, external laryngeal pressure, stillhead, bougie, etc. Okay, and then you do that. If you fail at this step, then you go to the next step, which is to put in a laryngeal mask. Okay. Once you put in a laryngeal mask, again, 2 attempts, saturation more than 95%. Once you put a laryngeal mask in, then you've got multiple options. One is you wake up the patient and do it some other day, or continue anesthesia using your laryngeal mask. And remember, you are using a 2nd generation laryngeal mask. So many surgeries can be finished on a laryngeal mask itself. And the third option, if you insist on intubation, is you intubate through the laryngeal mask. And for that, we say that you should use only a guided fiber optic guided intubation. Do not do a blind intubation through laryngeal mask, because if your tube doesn't go in a blind position, you are initially not able to intubate, your laryngeal mask was in, you have to take it out, and then you will lose the airway completely. So never lose the airway. Do a fiber optic guided provided expertise and a bronchoscope is available. Or you do a tracheostomy. Okay. If you fail with a laryngeal mask, then you're in trouble. Then you do what you do is rescue mask ventilation. Now, at this stage, we say you should ensure neuromuscular blockade. And so this is also similar to what the British guidelines say. And this is very important because people say, oh my God, you're not able to ventilate by mask or laryngeal mask, you're not able to intubate. Why you want to give relaxant? Why you want to make sure the patients relax? Because that is the best chance to get ventilation going. There should not be any laryngeal movement. There shouldn't be any laryngeal spasm. Okay. And then your next step is going to be a cricothyrotomy. This will give you the best attempt at a cricothyrotomy also. Okay. So ensure that the patient is well relaxed and give a final attempt using airway, oral airway, nasal airway, 2 persons bag mask ventilation. Try and do it. Try and get, if you're able to mask ventilate, fine, wake up the patient. If not, then we've got what we call as complete ventilation failure. You've not been able to ventilate by face mask, laryngeal mask, no tube. Call for additional help, extremely important. Right now, the anesthetist who's doing this case, he's seeing his career go down the drain. This patient is dying, and along with the patient dying, the anesthetist's career is also going to die. So he is not thinking properly. He needs to get someone with a fresh mind, with a fresh pair of hands, who can think rationally, who can think clearly, and do the sort of something over there. So then now you do a cricothyrotomy. And important, you do it, even if the oxygenation is well maintained, it's a good time to do a cricothyrotomy. Don't wait for the patient to become hypoxic. Okay. And then you do a cricothyrotomy. Now, initially we had said that you can use any technique you're familiar with, but I think we are going to change to the surgical cricothyrotomy, which is trachea, knife, incision, bougie, and tube technique. Okay. And so we'll have more guidelines coming up from the PUMA, the Project for Universal Airway Management. So I think today we are in a situation where we've got gadgets and we should have strategies to use these gadgets properly and wisely for the patient. So pre-oxygenation, today we use propofol. But if the patient is unstable or potentially unstable, like Dr. Sheila spoke, ketamine or etomidate for cardiostable induction, use a rocuronium for this thing, IPP by face mask, and intubate. If you can't, call for help, oral nasal airways, supraortic airways. Now you've got Stilet, bougie, video laryngoscopy, supraortic airways. But very importantly, now we've got Thrive to prevent desaturation. Always apply Thrive, right? Thrive and bag mask ventilation, or 15 liters oxygen, maintain blood pressure with vasopressors if required in some patients, and try and keep everything stable, oxygenation, hemodynamics, and everything. And hopefully we'll have a much safer airway for our patients. So thank you very much for the opportunity, and thank you very much for listening. And we'd be happy to take questions.
Thank you very much, Prof. Divatia, for that insightful presentation. And now we will move to the next question and answer session. I think we have 50 minutes more. I will read the question from the audience. If you have any additional question, feel free to drop them in the question and answer box. Please, Dr. Amal, can you share the question for the audience?
Okay, please wait a minute, Doctor.
I think we have 2 questions.
Yes.
Okay, this is the first question. I think this is for Professor Sheila, but I think you can also answer this, Prof. Intubating a critical ill patient with difficult airway is far more challenging than intubating a healthy patient with similar airway difficulties. My question is, can we use point-of-care ultrasound focused routinely to assess and manage difficult airway in ICU as a guideline tools? I think, as a standard, maybe. Or maybe you have some experience with it. Please, Prof.
Yes, so I think that's a good question about point of care ultrasound. Now you can use point of care ultrasound for the airway, and you can use point of care ultrasound for cardiovascular hemodynamics. Now, using ultrasound for the airway in a critical situation is maybe a little difficult, and you have to be a real expert in ultrasound to be able to do that. One of the uses is to locate the cricothyroid membrane. You can use it to diagnose tracheal intubation, but these are, I think those things are best for an elective situation. If you're doing an emergency intubation, I'm not, unless you're a real expert in ultrasound, it's very difficult to assess the airway. But where ultrasound or POCUS has a role is in the hemodynamic assessment before you start intubating and before you start giving drugs. And you can quickly diagnose whether the patient is hypovolemic, how hypovolemic he is, by looking in the inferior vena cava, by looking at the heart, if he's got cardiac failure or something like that. So that can help you guide whether you should pump more fluid prior to intubation or whether you should start a vasopressor up front or maybe a little bit of both prior to doing intubation. And even post-intubation, it can tell you what is the hemodynamic status of the patient. So I think, so that's roughly what I would say for POCUS as far as intubation is concerned, more for hemodynamic assessment, less for airway assessment. Does that answer the question?
Yes, I think it's no problem. Maybe the second question, Dr. Akmal, from Dr. Joel Lumintang. In case of suspected difficult intubation, how do the advantage and limitation of video laryngoscopy and fiber optic intubation influence your management strategy? And what patient factor might guide your decision?
Okay, so I think both are very good questions. And so if your difficult intubation is because of a potentially obstructed airway, right? For example, you've got a laryngeal cancer, you got a tumor in the larynx which is obstructing the airway, which is making your management difficult. In that sort of case, a fiber optic bronchoscope is probably not the best choice. Because what happens is, moment you put your fiber optic scope into the larynx, it will cause further obstruction, right? And you may have damage if you try and push a tube, you may cause bleeding or damage to this thing, which you can't see from what's happening outside. So in this situation, maybe a video laryngoscope might be preferable in the awake situation, right? Or a direct laryngoscope. So that's one sort of thing. Otherwise, a lot depends on the expertise that you have with the fiber optic device or the video laryngoscope device. If you have, let's say, a thyroid which is compressing trachea, I mean, you can use either. Okay? But because in thyroid, it is the laryngoscopy is unlikely to be difficult unless there's a lot of deviation, in which case you might have to. So you could use either sort of thing. But sometimes you could use a hybrid technique where you put do a fiber optic bronchoscopy and simultaneously do a video laryngoscopy to see where your fiber optic scope is going and whether it's sort of in the process of putting the tube in, whether you're damaging any of the tumors or tissue around the larynx. So the hybrid technique works sometimes. Now, as far as optimizing mask ventilation is concerned, I think, so there are 2 or 3 things which we must do. One is the position of the patient. So especially in obese patients, something like a ramp position works very well. Okay, and so the positioning of the patient is very useful. Slight head up position works because it reduces pushes the diaphragm down and it improves the FRC, gives you a little more better oxygenation. So that position is important. How you push the jaw up is useful. You can use a 2 persons, so 1 person to back mask, hold the mask, and 1 person to back the patient. So that person holding the mask can do it 2 hands. There are some debates on how you hold the mask. And the traditional is the CE technique, like this, holding the mask like this.
Mm-hmm.
And some now say just the thumbs over on the mask and the rest of the fingers lifting up the mandible. Okay, so the CE versus the VE technique or something they call. So you got different ways of holding the mask. Very importantly, you can use a combination of oral and nasal airways, or you can use both airways to prevent tongue fall and produce this thing over there. So I guess these are the sort of ways you would try and optimize your mask. And of course, you need to make sure that the patient is well relaxed, because if the patient has light anesthesia and is partly trying to vocalize or partly trying to cough, then your mask ventilation is not going to be very effective. And if that doesn't work, a laryngeal mask also works very well. So I think this is how you would optimize your mask ventilation. I don't know what is the practice in Indonesia, but when I was working abroad for some time, and it still happens, a lot of people use they give propofol and then they immediately put in a laryngeal mask with the patient breathing spontaneously, and then they maintain either on spontaneous ventilation or then they paralyze the patient or something and continue on laryngeal, laryngeal mask.
Okay.
What has
Use
happened in
propofol.
practice is people don't have lost the ability or don't have enough experience or practice with either mask ventilation or with intubation. So that skill has gone down. And we need to make sure when we train our postgraduates, our trainees, to make sure that they learn the technique of mask ventilation properly and they can hold a mask do a case for 20 minutes on a face mask and without obstructing the patient. So I think teaching our trainees how to do mask ventilation is also extremely important.
Okay, Prof. In your presentation, you mentioned that we can use nasal cannula to reduce the negative effect of the apnea before the intubation. Can you explain it one more time? Because I don't hear you so quite.
Yeah, so apneic oxygenation is very useful. And the question is, that when you give nasal oxygen from the nose, for the oxygenation to improve, it has to get into the alveoli. And most people used to believe that this just fills up the dead space. We need to make sure it's getting to the alveoli. And there is a physiology behind it. So you see what happens is oxygen is taken up from the alveoli. Say 250 ml per minute is taken up from the alveoli. And then with metabolism, carbon dioxide is produced. But all the carbon dioxide is produced does not return to the lung. A lot of it gets buffered in the tissues. So the amount of carbon dioxide returning to the lungs is much less than the amount of oxygen that is being taken up from the lungs. So there is a small negative pressure which is there in the alveoli. And if you give nasal oxygen at a sufficiently high flow, which is at least 15 liters, and maybe high flow nasal would be even higher, then that oxygen can actually get into the alveoli and improve oxygenation, right? So we must have, so that's a physiological basis for apneic oxygenation. Now for apneic oxygenation to be effective, three things have to happen. One is the FRC must be good, right? The functional residual capacity. So you should give a slight head-up position or, you must make sure the airway is patent, because the airway is not patent, then the oxygen is not going to go down, not going to reach the alveoli. So you need to have a patent airway. So even when you're giving high flow nasal oxygen, you should be making the airway patent. Usually when you're doing a laryngoscopy, your airway is going to be patent because you've got the laryngoscope in place, right? And you should have a sufficiently high flow. So with all these things, your nasal oxygenation during the apneic interval will keep the oxygen saturation higher for a longer period and give you more time to perform your intubation in case you have some difficulty. But don't do it after you've already got difficulty and the patients are desaturating, because by now the lungs have the FRC is reduced and all those complications started setting in.
Okay, Prof. Dr. Amal, maybe you have a question, another question from Dr. Amal mungkin you have live question.
Maybe not. Maybe to our other participant, we still have time for this question and answer session. You can type your question in the question and answer column.
No questions.
No question more?
There are lots of comments, but they're all in Bahasa, so I can't see. I don't know what they...
Okay, Prof. I think there's no more question. Okay. Okay, as we come to the end and before I close this session, maybe Prof. Divatia has any closing statement, Prof, or take home message for the audience, please, Prof.
Sorry, did you want me to say something?
Okay. As we come to the end and before I close this session, maybe Prof. Divatia has any closing statement to the audience
Yeah,
about the airway management.
So I think airway management, is, I think one thing that I have learned in so many years is you always respect the airway. And, people say I've got 20 years experience, 30 years experience. There's always be one airway which will bring you crashing down to earth. So always be humble when you see the airway. Don't think you can do everything. Just because you've got gadgets doesn't necessarily mean you'll be successful. Today, we are able to do much better with our gadgets, but I think one of the most important things are the human factors. We will not have time to go into the human factors, but how a person responds in times of crisis, how a person responds to difficulty also affects the management of the patient and the outcome of the patient. And that is something which we have to learn and practice. And there is where, say, like simulation, role playing, and all those teaching techniques sort of come into see. In a difficult airway situation, it's very difficult to teach on the spot. When the patient saturation is going down, you're trying to intubate, you can't tell your trainees, see, now this is what you have to do, this is the differential diagnosis. You can't do that. You have to first save the life of the patient. So teaching a difficult airway is difficult, but debriefing after the event, discussing after the event in a blame-free fashion. Not to say you don't say you messed up, you did an idiot, you did not know what to do, you did all nonsense. No, you sort of discuss to try and improve. So, discussing a critical incident, all this simulation, all that is very important in how we eventually respond to a difficult airway. Of course, you must know the algorithms, but they are just for guidance. But human factors play a very, very important role, and teaching and training in airway management is extremely important.
Okay, Prof. Okay. Thank you, Prof. Divatia, for your time and exercise, and thanks to everyone for your participation and fantastic question. I think see you again, Prof. Divatia in Medan. Thank you. You can come to the Medan.
See you all next week.
Okay, I will be. Silakan, Dr. Akmal. Thank you once again, Prof. Divatia.
Baik, terima kasih. Sampai sudah kita di penghujung acara webinar series ketiga dari rangkaian webinar series KPPIA Perdatin 2024. Sekali lagi, saya akan ucapkan terima kasih. I would like to say thank you for our speaker, Professor Divatia, for your insightful presentation. Thank you for your time, and maybe I can hopefully to meet again in the offline meeting at the KPPIA event symposium at 27 and 28 September 2024. Terima kasih juga kepada para peserta webinar series ketiga. Jangan lupa untuk mengikuti webinar series keempat, yaitu webinar series terakhir dari rangkaian webinar series KPPIA 2024 yang diadakan pada besok, pada hari Minggu, tanggal 22 September 2024, pukul 10 waktu Indonesia Barat. Sekali lagi, kami ucapkan terima kasih, dan jangan lupa untuk mengikuti terus seluruh kegiatan KPPIA Perdatin 2024, di mana akan dilaksanakan workshop pada mulai tanggal 24 hingga 26 September, serta simposium offline di Kota Medan pada tanggal 27 dan 28 September 2024. Akhir kata, wabillahi taufiq wal hidayah.
Mungkin foto jangan lupa, Dr. Akmal, foto dokumentasi.
Baik. Okay, Professor Divatia, before we close our webinar, can we have a documentation? Can you open your camera and look at the screen? We will take the picture. Make your, yes. We'll have a documentation. We'll take the picture in 3, 2, and 1. Okay. Thank you, Professor Divatia, once again for your time and your.
Thank you, Prof.
Yes.
Divatia. Thank you very much. See you in Medan.
Terima kasih kepada para peserta. Akhir kata, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Sampai jumpa lagi pada esok hari di webinar series terakhir, di webinar series keempat. Terima kasih, selamat siang.
Horas. Saya, Dr. Andriamuri Primaputra Lubis, selaku Ketua Panitia KPPIA Perdatin 2024, pada tahun ini, Perdatin Cabang Sumatera Utara mendapatkan kepercayaan untuk menyelenggarakan pertemuan ilmiah 3 tahunan berskala nasional, yaitu Kursus Penyegar dan Penambah Ilmu Anestesia atau yang disingkat KPPIA. Kami mengundang Anda untuk hadir dan berpartisipasi dalam kegiatan ilmiah ini dengan semangat kekeluargaan dan antusiasme yang tinggi, sembari menikmati segala keindahan, keunikan, dan keanekaragaman kuliner yang ditawarkan oleh daerah Medan, Sumatera Utara.
Saya, Irjen Pol Dr. Asependradiana, selaku Ketua Umum Perdatin mengucapkan selamat atas terselenggaranya kegiatan ini. Semoga acara ini dapat berjalan dengan baik dan lancar. Mari bersama kita sukseskan dan hadir pada acara tersebut. Wassalamualaikum warahmatullahi wabarakatuh.
Berikut ini adalah cara untuk membuat akun pelataran sehat melalui Satu Sehat SMDK. Pertama-tama, buka link satusehat.kemkes.go.id/sdmk, lalu klik daftar sekarang. Kemudian, isi data yang diperlukan yaitu NIK, nama sesuai KTP, jenis kelamin, tanggal lahir, email aktif, kata sandi, dan konfirmasi kata sandi. Lalu isi kode CAPTCHA dan klik daftar. Pastikan bahwa data sesuai, lalu centang pada kotak pernyataan bahwa data benar, dan klik konfirmasi. Silakan periksa email aktivasi di email Anda, lalu klik aktivasi akun. Setelah akun Anda berhasil diaktifkan, silakan login dengan menggunakan email dan kata sandi yang sudah Anda daftarkan. Jika sudah berhasil masuk di akun Satu Sehat, silakan klik menu pelataran sehat, lalu klik tautkan akun. Silakan centang kotak persetujuan setelah memahami persyaratan yang ada, lalu klik konfirmasi. Kemudian klik cari pembelajaran, setelah itu Anda harus melengkapi data diri. Jika sudah melengkapi data diri, maka Anda sudah bisa mengikuti pembelajaran yang ada di pelataran sehat.
majulah.